Good morning everybody, this is Dr. Sachin Nepali. Today's presentation is on occipital lobe epilepsy. These are the contents for today's presentation, and I would like to start my presentation with the case vignette. 13 years old female, she presented with the total duration of illness from 9 years, and course was multiple episodes in between. That means the symptoms was started when she was 4 years of age. She had frequent episode of falling down, not aware of surrounding her. There was hand flexion and extension, and there was history of smiling, head nodding, clapping, eye blinking, and moving her lips with the finger. And similarly, there was history of light flashing and flickering before the episode, and such episode lasted around 2 minutes. There was also history of 2 episodes of strengthening of limbs, tightening of fist, frothing, uprolling of eyes, stool, and urine passage, and this occurred for around 5 minutes. No history of fever, no vomiting. Regarding birth history, a normal vaginal delivery at hospital at 9 months of gestation, and her weight was 1200 gram, and she was admitted in NICU for around 16 days, and she was kept under oxygen. There was no family history of such episode. Here I would like to show the video of the patient, which the patient party had recorded, and here we can see the video. You can observe the movement around the eyes. There is movement in the hand, and this is automatism. She is frequently moving her eyes, and we can also observe she is touching her lips. For this video, the consent has been taken from the patient party and has been used only for the educational purpose. The MRI finding of the patient has been shown in the figure 1 and 2. So in the figure 2 is the enlarged part of the figure 1. In the figure 1 and 2, we can see the area which has been shown with the yellow arrows. There is high intensity lesion in the occipital lobe. This is the MRI finding of the patient. Now the anatomy of the occipital lobe. We can see the 3 pictures, figure 1, 2 and 3, showing from the different side of the brain. In the figure 1, we can see from this is the lateral view of the occipital lobe. This is the occipital lobe, and in the second figure we can see the occipital lobe marked by the red areas. This is from the inferior view, and this figure 3 is from the posterior view. This blue portion is indicating the posterior part of the brain, and these are the occipital lobes. Now moving towards topic proper. What is occipital lobe epilepsy? This is a condition characterized by recurrent unprovoked seizure originating from the occipital lobe. Regarding epidemiology, this has been taken from the article which has been mentioned in the slide. As per that article, this is relatively uncommon and probably maybe because of the underdiagnosed cases. And as per that article, in a newly diagnosed epilepsy cases, occipital epilepsy was found in 1.2 to 2.6%. That means the cases from this also we can know that the cases are relatively uncommon, or relatively fewer cases of occipital lobe epilepsy. Now, what are the causes of occipital lobe epilepsy? The causes of occipital lobe epilepsy: genetic cause, and tumor, benign tumors, gangliogliomas, dysembryoplastic neuroepithelial tumor, neoplastic astrocytoma, oligodendrogliomas, the trauma and vascular, bilateral occipital calcification, perinatal anoxic ischemic injury, perinatal posterior cerebral artery occlusion, post-traumatic occipital gliosis, post-stroke infarction or hemorrhage. And in the infective chronic encephalitis, localized infection, tuberculoma and cysticercosis. In the metabolic cause, mitochondrial disorders and hypercalcemia. So when we relate this cause to our patient, she had also undergone the perinatal anoxic ischemic injury, and there was a history of admission in NICU for around 16 days, and continuously she was under the oxygen. Another cause is the idiopathic. In idiopathic, early onset childhood epilepsy with occipital spikes, late onset childhood epilepsy with occipital spikes, and idiopathic photosensitive epilepsy. In the malformation, cortical dysplasia, occipital periventricular heterotopia, and subcortical band heterotopia. And other causes are malignant hypertension, eclampsia, and drugs like cyclosporin and tacrolimus. What are the features of the occipital lobe epilepsy? Visual phenomenon, aura seen in more than 80%, and like flashes, floating stars and zigzags. We can see those in the pictures also. These are all the elementary hallucination. That means poorly formed hallucination, either only flashes or floating stars or zigzags. And also there could be complex visual hallucination, and other features could be like abdominal or somatosensory phenomenon. If the occipital temporal area will be affected, then more complex and colorful hallucination will be present. An illusion may occur, that is change in the shape and size of the object, and object appear to be at distance. That means whenever, for example, if the belt is shown to the patient, then he or she could perceive as it is a snake. So this is one example of illusion. And ictal vomiting could be there, and eye deviation. And another feature is the forced closure of the eyelids and palpebral jerks. If the seizure spread to the temporal lobe, then there could be features like automatism and impaired awareness. Now, benign childhood occipital seizures, in short form it is known as the BCOS. The prevalence of this benign childhood occipital seizure is 20 to 25% of the childhood partial seizure. This is of two types. One is early onset and another is the late onset. In early onset is also known as the Paniotopoulos type, and late onset is known as the Gustav type. About early onset benign occipital lobe seizure, onset is around 1 to 14 years, and mean age is around less than 5 years, and prevalence of early onset occipital seizure is 6.7% to 13% of the childhood focal epilepsies. Here the vomiting is common, and other features are irritability and deviation of eyes, sudden loss of muscle tone, unresponsiveness, and visual aura that is variably present. So in this early onset benign temporal occipital lobe epilepsy, autonomic features are most common, and other autonomic features are pallor, flushing, urinary incontinence, and coughing. The duration of early onset occipital lobe seizure is around 5 minutes, and in 1/3 to 1/2 of the patient, the duration could last for more than 30 minutes. Now the late onset benign childhood occipital lobe epilepsy, onset is around 3 to 16 years, and mean age is from 8 to 9 years. In this late onset type, visual symptoms are more common, that is blindness or elementary visual hallucination. In early onset, we had discussed that the autonomic features are common, but in the late onset, visual symptoms are most common, and other features are automatism, migraine-like headache, and later this may secondarily generalize too, and duration is around less than 5 minutes. When we compare with this early onset, then the duration is around 5 minutes. In some cases, this may extend up to 30 minutes, and in late onset, the duration is less than 5 minutes. After this, idiopathic photosensitive occipital seizures, onset is from 5 to 17 years. It is seen in 2 to 7% of the benign childhood focal seizures. This could be induced by television or video games. That is, this type of seizure will be induced by the photic stimulation. In this type of seizure, visual hallucination with blindness is common. There is also deviation of eyes, vomiting, headache, and generalized convulsion too. Duration is around 2 to 5 minutes. In some cases, duration may last up to 2 hours. Now, epilepsy with bilateral occipital calcification. In these cases, seizure onset is in the first decade of life, and initially there are visual and motor signs, and later that may evolve to the tonic-clonic seizure, absence seizure. And in this type of epilepsy, intellectual deterioration may occur. That means there could be the presence of subnormal intelligence, and often this is associated with the celiac disease, and it is an autoimmune disease. So how to diagnose the occipital lobe epilepsy? First is the clinical history. We need to explore all the features which we have described in the slide before, and in that birth history is important, and after that clinical history, MRI and EEG, that will help in the diagnosis. Now in the MRI, here we have shown the two pictures. This first one is which I had already explained during the case vignette, and this is the MRI of our patient. Here we can see this occipital lobe, and there is high intense lesion in the both occipital lobes. Similarly, in this second picture, there is also lesion shown in the occipital lobes. Now after that, EEG. This is the EEG of the patient which we had described in the case vignette. In this we can see these spikes here. Spikes in the here we can see the spikes in the temporal and the occipital lobes. Here is also spikes in the temporal and occipital lobes. And after this EEG is of a 5-year-old boy. This shows the discharges of occipital bilateral spikes in the right-sided electrodes of the occipital lobes. They have shown these spikes in the EEG. Now the treatment: anti-epileptic medication like carbamazepine, oxcarbamazepine, levetiracetam, lamotrigine, and clobazam. Similarly, for the photosensitive seizure, avoidance of precipitating factor and sodium valproate is more effective in photosensitive seizure. And regarding surgery is done for those cases who are refractory to the anti-epileptic medicines. In such cases, the surgical options available are occipital lesionectomies, multiple subplial transection, laser interstitial thermal therapy, and stereotactic radiosurgery. Now, what is the prognosis of this occipital lobe seizure? If that is of early onset benign childhood occipital lobe seizure, half or 50% may not need medication, and spontaneous remission in 2 to 3 years after the onset. In cases of the delayed onset benign childhood epilepsy, seizure can be frequent and need the anti-epileptic medications. Similarly, in cases of the idiopathic photosensitive occipital seizure, the prognosis is uncertain and may occur 1 or 2 episodes, or may not remit, and there could be mild cognitive impairment too. Now, if the occipital cortical dysplasia, then these are often refractory to medicine, and surgical resection results the good outcome. Similarly, if there is occipital periventricular heterotopia, then these are also often refractory to medicine, and regarding surgical resection, that is not much good outcome. And in the bilateral occipital calcification, surgical resection results the good outcome. Now here I would like to present one article on surgical treatment of occipital lobe epilepsy. In that 54 patients were enrolled, and later 2 were excluded because of not fulfilling the data properly, and overall in 52 patients, 96.2% had structural lesions, and in that more were having glial scars, that is 28.8%, and then vascular malformation, cortical dysplasia, gangliogliomas, and other tumors. Now After the surgery, there was follow-up after 80 months, and 69.2% were seizure free, and around 15.4% greater than 75% improvement was seen, and in 4 cases there was no improvement. And this study also revealed that the early age at epilepsy manifestation and shorter epilepsy duration were predictive of better seizure control, and overall satisfactory results were obtained in 77% of patients in the series of this study. And post-operative visual field defect occurred in a significant proportion of patients. And these are the references for the today's presentation, and thank you.